ketogenesis. Okay. So we are going to have ketogenesis. We are going to decrease the alkaline reserve. And there is going to lead to the ketoacidosis and lactic acidosis. But other way, the proteolysis. We are going to start to stop the protein synthesis. And we are going to start to break the protein. This is going to create more substrate for the gluconeogenesis, and we are going to have more hyperglycemia. We are going to increase the glycogenolysis. So all this is just to cause the increase of the glucose in the blood. We are going to have more hyperglycemia. We are going to get the threshold of 170 to 200 milligrams per deciliter of glucose, and this is going to lead to the glucosuria and osmotic diuresis. The patient starts to lose water and electrolytes. He gets in the dehydration state, impaired renal function, and the state of hyperosmolarity. So we need to have some biochemical finding for the diagnosis of the DKA. So the first is the hyperglycemia. We are going to have the glucose level in blood of more than 200, more or equal to 200 milligrams per deciliter. We are going to have the pH less than 7.3 or bicarbonate less than 15. And something that I didn't see that we do in the hospital, but we need to have the ketonemia. And for this, we are going to measure in blood the blood beta hydroxybutyrate. And the concentration must be equal or more than 3 millismol per liter. And in the urine, we are going to have the moderate or large ketonuria. So we need these 3 points to diagnose the patient with the DKA. Now, the signs and symptoms is very important that we take a proper clinical history, because some patients can just arrive with the clinical, the classic clinical signs and symptoms. That is, the polyuria, polydipsia, polyphagia, and the weight loss. But some patients can even present with this advance. The parents don't look for attention before, for the social economical issues, or because the patient is less than 2 years old and they cannot just express that I want to drink more, or they are they have polyuria. So the patient advances clinical signs and symptoms, and they start with vomiting, abdominal pain, dehydration. The patient can be weak and lethargy. So they have abdominal pain. The abdominal pain in this patient sometimes is so severe that we can confuse with acute abdomen. So that is why we need just to interview the parents too, and to see and to look for a well history, because some patients can be admitted for a acute abdomen and they just have the DKA. So this abdominal pain is going to be caused because the pain for the ileus, because we have the potassium depletion, is going to be for the acidosis, and we have the poor splenic perfusion. In the patient, how we see some of the regulatory hormone is the catecholamine. So what happened, that the catecholamine is increasing the vascular tone, so the patient can keep the blood pressure for a long time. Even I read that there is a study that said that some patients can present with hypertension. But if the patient continues the hydration state, we can find that the patient is tachycardic. Is going to have delayed capillary refill time. The patient is going to have the poor skin turgor and dry mucous membrane. How the patient is acidotic, the body just look to correct this acidosis. How is going to do this? He just want to lose PCO2. So the body start to compensate, and the respiration become deep and fast. And that is what we call Kussmaul respiration. 2, we can feel a smelly odor to fruit in the patient breath. how we say that the patient have severe DKA. So when the compensatory mechanism are already like overwhelmed, these children with severe DKA at that moment can present hypotension, shock, and altered mental status. The more severe complication of DKA is going to be the severe neurologic injury and the cerebral edema. But too, we need to follow the patient because they can present like arrhythmia, ventricular arrhythmia for the hyperkalemia or hypokalemia. So that is why how this the more like fear complication in the cerebral edema. We need to monitor this patient after they are admitted in the PICU. Every hour, we are going to do like a neurological exam. So we are looking for some like warning signs and symptoms. That is like the headache, the patient presenting with the bradycardia, and the hypertension. We know that this is like the Cushing triad, right? But too, we need to continue follow this patient for any irritability. If the patient increase the drowsiness, alternate mental status, any cranial nerve palsy, any new and normal neurologic signs on examination, or if the patient turns like unresponsiveness or in coma. But we just know for all this, we need to do like the neuro evaluation, we need to add to the Glasgow Coma Scale. This is like the score of the Glasgow. And here we see like the evaluation. This can use to provide like the more objective, right? Objective assessing to the neurological exam. So we need to check the patient for a neurological examination complete and to check for the Glasgow Coma score. This we don't do because you can ask why we just don't use the Glasgow. It's better, we don't have to do all the neurological exam, but the Glasgow is just limited. It's not going to be well validated like a predictor for a short or long-term outcome in any pediatric patient with DKA. So we need to do both every hour in the beginning of the presentation. So in the lab values, we are going to, the severity of the DKA is going to be like divide or categorize as mild, severe, and moderate. So we have the mild one is when the patient has a pH or less than 7.3 and bicarbonate less than 15. We have the moderate one where the pH is less than 7.2 and bicarbonate less than 10. And we are going to have like the severe DKA when a patient has a pH less than 7.1 and a bicarbonate less than 5. It's important too, the value of the serum electrolyte, because with this we are going to calculate like the increase of anion gap. We know the anion gap is going to be like the addition of the add of the chloride plus the bicarbonate. And to this value, we are going to subtract the sodium. To be consistent with the DKA, we need to have an anion gap more or equal to 12, more or less 2 milliequivalent. We need to rule out 2 other causes of anion gap acidosis. Give me a second. So this is what is other causes of anion gap ketoacidosis. Is going to be, for example, the MOD-PI, right? Lactic acidosis, salicylate, the methanol, etc. So the patient too, we are going to see that they have like the hyponatremic state, but this is going to be causing for the hyperglycemia. So we need to calculate like the correction of sodium. And this correction, this is like a formula, the sodium plus 2 is going to be multiplied for the plasma glucose less minus 100 and divided for 100. So. And we are going to have what is consistent with DKA. We are going to have elevated serum osmolarity, we need to calculate the osmolarity of the plasma, of the serum. Then we know that it's twice the sodium plus the glucose divided into 18 plus the boom, then it's the blue urea nitrogen divided into 2.8. So we need to see if the patient has an elevated serum osmolarity. We are going to check for the blue urea nitrogen, creatinine. It's important to know that when we have like very high level of blood urea nitrogen and creatinine, that is consistent with a bad prognosis too. Other labs that we need to follow is not just for the diagnosis, but to see if the patient have any infection, the CBC. We can, even in a patient with DKA, even they don't have any infection, they just report like leukocytosis and with the left shift. This is for the stress and for the same hyperglycemia. So we need just to rule out that the patient have any infection, if they need any culture, urine culture, blood culture, or any culture of any other fluid in the body. If the patient need any check X-ray, we will know when we check the patient for the signs, symptoms. And we have the serial laboratory testing. This test is the one that we are going to do like every hour. For example, the capillary blood glucose. At least when the patient is like in shock or very dehydrated, we are going to do like a peripheral sample, a venous sample. We are going to check for the serum electrolyte and the blood gases every 2 to 4 hours. In the lab too, the patient presenting in DKA with a new diagnosis of diabetes, we want to know if the patient have like a type 1, right? Or type 2. So this is not like emergency to do this lab, but we need to know that eventually we are going to send for them. And it's like the hemoglobin A1C, the thyroperoxidase antibodies, the free tyrosine, tissue transglutaminase, immunoglobulin A, the island cell antibody, the total immunoglobulin, the glutamic acid descarboxylate antibody. When they are positive, it's because there is like any autoimmune disease, and that happens with the type 1. And the one that is that is positive in a 30 to 60% of patients is the thyroperoxidase antibody, because when they have almost a problem with thyroid, autoimmune thyroid diseases. So what is the treatment overview of this patient? The overall goal of the treatment of the DKA is first to correct the dehydration. We need to correct the acidosis and reverse the ketosis in this patient. We are going to do gradual correction of the hyperosmolarity and the hyperglycemia. For this, we are going to use the careful fluid resuscitation. We are going to do the insulin administration after the fluid resuscitation. We are going to do the electrolyte replacement and the close monitor for signs of cerebral edema. In the initial treatment or management is always the fluid. We are going to resuscitate the patient with isotonic fluid, and we can give the bolus of 10 or 20 milliliters per kilo of saline and 0.9%. Even we are going to first time the infusion with insulin, or the drip with insulin, we are going to replace the fluid, right? And we are going to calculate the fluid administration with the replacement from the losses and the maintenance too. And this is going to be in a, should be estimated over 24 to 48 hours. And they can be used, before they said that just 0.9, but now in a new study, they said that no, we can even replace with 0.45% of saline. So that is the study, right? And they say that there is no it's no difference when we use the fluid based on 0.45 or 0.9%. And usually the patient with DKA have a dehydration of 5 to 10%. So after the fluid replacement, we should follow with the rate of insulin. The insulin rate is going to be like in a drip or constant infusion with a rate of 0.05 to zero point 0.1 unit per kilo per hour. And this is going to depend of the clinical scenario and the degree of hyperosmolarity. And what we expect with this is to decrease the glucose to 36 to 90 milligrams per deciliter per hour. So we can add glucose to this fluid when we see like the rate of decrease drop faster than what we expect. So this here is like the part of the treatment. It's like the two-bag technique. So before we are going to add to this two-bag, so the electrolytes. And this is going to depend of the institution, of the hospital and the protocol, and two of the patient. What we find in the patient, the labs, or the result of the sodium chloride, the result of the potassium acetate, or the potassium phosphate. In the article, they said that they add like 30 milliequivalent of potassium acetate to each bag and 10 milliequivalent of potassium phosphate. In our hospital in Rome C, they just add like 20 milliequivalent of potassium acetate and 20 milliequivalent of potassium phosphate, at least on the labs of the scenario of the patient is different or change the level of phosphate or the acetate. So this is right now how we use. We are going to prepare two bags, right? One of them is just 0.9 saline, and the other, the second bag, is dextro 10% plus the saline and 0.9. And to these two bags, we are going to add the electrolyte, and I show you in the same amount of each one, each bag. So if the patient have like the glucose more than 250, we're just going to add to give to the patient the sodium, the 0.9 saline. If the glucose of the patient is, the plasma glucose is 200 to 249, we are going to give like the 1 part of each bag. We divide like in 2 parts and half. One of the bag number 1, then it's just the saline and 0.9, and the second bag with the dextran 10 to plus the saline and 0.9. So what are we giving a concentration of dextro of 5% in this moment. Now, if the glucose, plasma glucose level is lower, like 150 to 200, we are going to divide to the fluid that we are going to give into the patient to four parts. One part is going to be just the bag 1, and the third part is going to be for the bag 2. In this, we are giving in this way a concentration of glucose of 7.5. Now, if the glucose level is going to less than 150, we just give the bag 2, that is like the dextran 10% plus the sodium, saline, and 0.9. And this is giving like the final dextro concentration on 10%. So when we treat the patient with DKA, we need to know that the typical total body potassium is in deficit. First, because the intracellular potassium is going to be depleted because the shift of the potassium to the intracellular space to the extracellular space. And the patient is continuing losing potassium for the vomiting and the osmotic diuresis too. So if the children is hypokalemic in the moment of the presentation, we can just replace potassium right away in the first bolus that we give. Now, if the patient have like adequate potassium level, normal or high in the first lab, we first have to check that the patient have like an adequate urine output. And in that moment, we are going to provide the potassium in the maintenance fluid. So what about the bicarbonate? Bicarbonate administration is not recommended because it has not shown any benefit in the resolution of DKA, and the bolus administration has been even associated with worse outcomes. So we're just going to give bicarbonate in this patient for two reasons. First, if we want to treat like a severe hyperkalemia and the patient have like a severe acidosis with a pH less than 6.9, and this is causing like the impair of the cardiac contractility, we are going to give the bicarbonate. And the second scenario, then we are going to give bicarbonate in the hyperchloremia. The hyperchloremia may develop in any children that we are replaced like the fluid. And this fluid contains a large amount of chlorides. That is the case of the 0.9 saline. And this can contribute to a persistent hyperchloremic metabolic acidosis, the large basic deficit, and a low serum bicarbonate level. So how we can consider that a patient have hyperchloremia? Because already this patient is in acidosis, have a DKA, but we need to know if this is because high chloremia, for high chloride in the blood. We need to consider this in a children that have the acidosis. But in this case, it's a non-anion gap metabolic acidosis. We know that DKA is an anion gap. We are going to have a low serum bicarbonate, and when we measure in blood, the ketones, like the beta-hydroxybutyryl level, are low too. So we can say that this patient have acidosis because hyperchloremia and need to be treated with the bicarbonate. The complication, how I say, of the DKA is the cerebral edema. The pathogenesis of the cerebral edema is not well understood. So they say that it's more multifactorial and complex. We know that before they suggest that it's because the IV fluid administration, because we administrate very fast, or because the content of the fluid. But right now, they even have different theory for this, and they said that the older theory is about this. They said that cerebral edema is just because we rehydrate fast with hypotonic fluid, and this is going to result in the fluid shift. So we are going to decrease a fast or rapid decrease in the osmolarity between extravascular and intravascular in intracranial compartment. And this is called like the cerebral edema. Right now we have like a newer theory that they say that the cerebral edema is causing because the hypoperfusion. There is, after the hypoperfusion, we are going to have reperfusion injury, neuroinflammation, vasogenic edema, and increased permeability of blood-brain barrier. They base this new theory because they see that in patients with DKA, they can have like long-term sequelae. Even the patient doesn't have like a cerebral edema in the moment of hospitalization. In the future, they have some deficits, like neurological deficits, some of them. So how we are talking about the cerebral edema, this is what we are going to find in the CT scan. In the cerebral edema, we see in this tomography, like the effacement of the sulci, brain sulci. So this is. It's important to know how to treat. Even the topic is about DKA. It's important to know when the patient, we see that they are presenting the warning signs of cerebral edema, we need to treat this patient with, for example, measure of the elevation of the 30 grade of the bed head of the patient. We can administer like the hyperosmotic solution, 0.9. We can give mannitol too. So in summary, the summary of this is based in evidence, right? So based on evidence, they just classify in D, A, and B. The A and B is what is in the guideline. So we need to do for sure. And the D is something that is like in discussion still. So in this article, we see that in all the investigation, the researchers, that on the basis of class D evidence and consensus, Children and adolescents with DKA should be cared for in a center experienced in the treatment of DKA. So Class A evidence is that the goal of the treatment in children with DKA are to correct the hydration, we need to correct the acidosis, and we need to reverse the ketosis. On the basis to this is a Class A evidence, the fluid replacement must be for the deficit and the maintenance. And this is going to be, should be calculated and replaced over 24 to 48 hours. So in the Class B, that still must be in the, or should be in the guideline, is in the insulin therapy should start at a rate of 0.05 to 0.1 unit per kilo per hour after starting the fluid replacement. In the basis of Class B evidence, the bicarbonate administration is not recommended, except for severe hyperkalemia or severe acidosis with impaired cardiac output. And that's it. I have some questions too. I don't know if we have time to do it or not.
Thank you, Natasha.
Well,
Thank you, Natasha.
Natasha, that was a good presentation. It's 8:45. I think you have time for questions.
okay, you are there.
You have 15 minutes, right?
Yes. So we are going to do the questions, right? So this is the first question. If somebody wants to read this. Who is there? Zoom, maybe?
Yes, a 16 years old girl with type A diabetes is seen in the clinic for recurrent episodes of DKA. She is 5 feet 6 inches tall and weighs 100 pounds. She is a well-adjusted honor roll student, and her teachers say that she is a very pleasant person and gets along very well with her peers. Which of the following is the most likely to be associated with her recurrent episodes of DKA? Oh, I did these questions yesterday.
Oh, you see? So you know now.
Yeah, yes. And that is an insult. Oh, no, that's the same question, not the same question. So I'll read it. A, fear of weight gain, and B, inadequately prescribed dosing of insulin, and C, no socioeconomic status, and D, misunderstanding insulin administration instructions, and E, underlying immune disorders predisposing to infection. Well, the question I did yesterday, that's the girl is not compliant with her insulin injection, but we don't have this choice here, so I may choose C.
So remember that it's like a teen, right? This patient, 60 years old girl. So let's go see. So the right question is A, fear of weight gain. So this is the, you can read the answer.
Oh, in the recurrent DKA, psychological considerations play a major role, including stress of chronic disease, rebellion against authority, fear of weight gain, and eating disorders, which all have been implicated as contributing factors. Increased risk of recurrent of DKA.
Okay.
Of DKA has also been reported in peripubertal and adolescent girls and children with challenging social situations or limited access to medical services.
Good. So this is the second question.
Do you want me to continue to read?
I don't know, but we have Mohammed, no?
There's no other resident on the call?
I can continue to read.
We're getting ready to go to walk out to the clinic. Some of us.
All right. So there's no one else except the clinic
I can read the third one. I just need a little some time. I can read the third one. Mohammed is on the call.
Yeah, Mohammed, you can do this one, please.
Yeah. And there's no floor people either? There's like floor residents, other residents?
I can read. A 3-year-old girl with a new onset type 1 diabetes mellitus is admitted to the hospital with a diagnosis of DKA. On initial evaluation in the emergency department, she was assessed to be severely dehydrated. Her parents report that she has been ill for a week. Laboratory studies show mild acidosis, high urine-specific gravity, glucosuria, and ketonuria. Which of the following factors is least likely to place this patient at a risk of cerebral edema? Age of 3 years, mild acidosis, new onset type 1 diabetes mellitus, prolonged nature of her illness, severe dehydration. Least is, I think, maybe mild acidosis. I'm not
Yes, I
sure.
agree.
Yeah, good. Very good. Answer is there, right there. Well, that is the explanation, Daniel.
One second. So demographic factors associated with an increased risk of cerebral edema include younger age, less than 5 years old, new onset of diabetes, longer duration of symptoms often associated with severe dehydration and severe acidosis. Okay.
So this is the other question. You can do it, Mohammed, now. I think Santos.
Okay. A 10-year-old girl with no significant medical history is brought to the emergency department because of vomiting, abdominal pain, polyuria, polydipsia, dehydration, and weight loss. She is diagnosed as having DKA in addition to blood glucose, blood ketone, and serum electrolyte level. Which of the following lab studies is not recommended as part of the initial routine evaluation of this patient? Erythrocyte ESR, glutamic acid decarboxylase antibody level, hemoglobin A1C level, islet cell antibody, cyroperoxidase antibodies. Okay, for the emergency, this emergency situation, I won't do the TBO antibodies.
So that is the not recommended. Which one?
Yeah, not recommended. Number E.
Oh, yeah. Yes, sir.
ESR.
Mm-hmm.
Oh. So why we do it? Okay, rationale. This testing is inclusive of hemoglobin A1C, thyroperoxidase antibodies, thyrotropin, free thyroxine, tissue transglutaminases, immunoglobulin A, a total immunoglobulin A, islet cell antibody, insulin antibody, and the glutamic acid decarboxylase antibodies.
Because this is just for the diagnosis, right? To know if it's a type 1 or type 2 diabetes mellitus.
Yeah, I know the diagnosis is not established yet, but in this situation, I won't go for the thyroid problem, especially if he had no symptom.
Yeah. ESR is not like a routine test. So this is, we don't have more. Dr. Mendez, are you there? Because no more. I already showed.
I'm here. I'm here. If we're done, we're done. Thank you. Good presentation. I'll see you in a few minutes. You still have 8 minutes to get to clinic.
Yeah. Let's go to Cordero. Thank you.
Thank you, Natasha.
Thank
That
you.
was
Take care, guys.
amazing.
Thank you, Natasha.
Welcome back, Naveen.
Oh, thank you, Dr. Mendez. How are you?
Okay, bye. Bye.
Okay, bye.